electronic, but I don't know how to get an electronic bottle of water yet. I like to stand away from the podium, so can you still hear me if I stand here? Yes. Excellent. Although now I can't see anything because there's a light on my face, but never mind. Right, another piece of technology is this. I love these things, they're great. They even work, that's even better. Right, so if I'm trying to stand without the spotlight on me, that's better. It's strange how things work out, because 5 years ago when I started at NHS Digital, I never thought I'd be stood at the Royal Society of Medicine talking about knitting. And I was fascinated to hear an example of knitting. And my only anecdote I can say about knitting is that, did you know that Sylvester Stallone uses knitting to help with his stress relief? And there's probably a terrible film called, I think it was called Demolition Man, from the either 80s or 90s. It's a typical Stallone film, so I wouldn't recommend watching it. But thinking about knitting is probably the most realistic part of that film, and it's a long film, but knitting gets everywhere. So if it's good enough for Sylvester, it's good enough for the rest of us, so I will consider that. I was trying to think of how I can move from knitting to data, and I failed entirely on that one. So, right. So what's the role of NHS Digital? There's lots of ALBs and lots of different parts of the NHS, so I thought I'd give a very brief overview of what NHS Digital does. We're the National Digital Data and Technology Delivery Partner of the NHS. So we do a lot of technical things. We do a lot of things like the e-referral service, used to be Choose and Book. We do the electronic prescription service. So this is the technology side of it. My part is the data side. So we have responsibility for collecting, protecting, linking and disseminating health data across England. So that's the side that I get involved in. And last year we did 265 official statistical publications. So NHS Digital, two arms, technical side, data side. I work on the data side and I work on mental health. Role of the mental health team. So my team, we collect data each month. We collect lots of data. We work with providers to improve the quality of the data, publish lots of statistics. The publication generally is fairly straightforward once we've got the data. We develop new analysis. So it's doing the new measures, which is tricky. How do you count things? It sounds very straightforward, but there's lots of different views of how you count things. And then we don't just keep the data for ourselves. We like to let other people use the data. So we create extracts for people. So when we get a request for data, we try and create the extract that they need to help them with analysis, their own understanding of services, etc. We answer parliamentary questions. So it's quite interesting that Parliament was sat yesterday, so we've got some questions through, which we haven't done for the previous few weeks, and respond to Freedom of Information Act. So that's our general work that we do every month. What mental health data is collected? Lots. We collect lots and lots of data. I'm not going to list all 573 data items that we collect, but there are lots of them. Instead, I want to look at the three ways that we collect data. We collect aggregate collections. So we mentioned early interventions in psychosis, the first NHS waiting list for mental health in earlier talks. Aggregate collections are, tell us how many. How many patients did you treat? How many patients waited less than 2 weeks? So fairly simple, but a bit limited. We collect monthly data via the Mental Health Services data set, and that's most of what the work of the department does. And we collect occasional in-depth survey data. And I'll speak some more about the Children's and Young People's Mental Health Survey later. We prefer to collect data regularly, because then we can see timelines, we can see improvements, we can see benefits, etc. If we collect data once and use it many times, we can start to reduce burden. We're very aware that collecting data is burdensome for providers. It's necessary, but it does cost time and effort to collect the data and to send it through to us. So we are trying to minimise that burden whenever we can. If we collect the data once and use it for many, many different things, hopefully we get to a single version of the truth, rather than one collection saying one thing and another collection saying another thing. So aggregate data collection. In some ways, this is the most simple, often established when the data set doesn't contain the data. So early interventions in psychosis, the first waiting times for mental health, we didn't collect that data in the data set. So we issued an aggregate collection. And again, we just asked people how many. Similar thing for children and young people's eating disorders, waiting times not collected in the data set, and delayed transfers of care. They're relatively quick to establish, relatively low burden. I'm saying relative because we know they still cost money to collect. Disadvantage is they're limited in what they can tell us. If we ask you how many patients you treated in early interventions in psychosis, that's all we know. We don't know where they've come from, where they're going to, what happened to them before, and what happened with them after. We can't break them down by age very well. We can't break them down by ethnicity. We can't really say much about them. All we know is the question that we asked you. And often, in the case of the two measures at the top, they duplicate data that we already collect. When these waiting times first came in, we didn't collect the data in the data set. We updated the data set, so it now does collect the data, but the two things aren't in sync yet. So we ask you once how many you've done, and then we ask you to send us lots of patient-level data about the same thing, which isn't very helpful to anybody. It's not helpful for you because you duplicate the effort, and it gives us two answers to any question that you asked, which is unhelpful from a stats point of view. So the mental health services data set is a patient-level data set. The aggregate, we ask you how many. The data set, we want details of every single patient that you see. It's service and activity based. So if a patient has activity in the NHS at a mental health provider, we want to know about it. It's not population based. So if you have a patient who's got a mental health condition but never comes to the NHS, never sees a service, the data set would never know about that patient at all. So a bit of a blind spot there. We update the structure of the data set every year. We try to keep it up to date. We didn't collect data on the waiting times when it started, and now we do. In the intro, Jackie mentioned that we collect data from 170 providers. I'm very pleased to announce that as of last Thursday, we now collect data from 202 providers, and we still think we've got a lot more to go in getting more and more data. The more data that we can collect from providers, the more we can give a more accurate and useful picture of how services are running across the country. As I mentioned, the data is comprehensive. We collect hundreds of data items. It's a secondary uses data set. The aim is to reuse patient data that you already collect. The aim is that we don't ask you to collect new data. We collect data that you should already be collecting as part of your clinical operations, and we just ask you to send it to us. We know that's not always true in all cases, but that's our aim. We want to minimise the burden of data collection, and obviously we have a long way to go there, and we're working to reduce the burden of submitting data, which I'll come on to in a bit later. Milestones. The mental health data set has been around for a long time. 2003 was the first year it was collected. First publication was 2008, so it had a long period of trying to get the data useful. In 2014, we expanded the data set to include learning disability services. Rather than having a separate collection for learning disabilities, we expanded the mental health data set. And in 2016, we expanded it to include children. So whilst between 2003 and 2016 we talked about the mental health data set, it only included adults. Didn't include any data on children whatsoever. So from 2016 we expanded it. So now it's an all-age data set. From 2020, so next year, we'll allow providers to resubmit data, which we're hoping will improve the quality of the data that we collect. Current uses. I won't go through all of these. We try and make the data useful for as many people as we can. We publish lots of data every month. We publish more data every year. We try and allow other parts of NHS Digital to use the data and other parts of the NHS broader community to use the data. Public Health England's Fingertips tool is well regarded in the mental health circles. We collect the data, we give the data to Public Health England, and they reanalyse it and reuse it so that there's a wider benefit of the data that we collect. And research. Any researcher can ask for the data that we collect, subject to appropriate guidelines, etc. So that's enough about what the data is, how the structure we collect it. As an example of what we do collect, Mental Health Act. We used to collect the Mental Health Act on an aggregate return called KP90. And that was a quarterly return, so we could say what happened every quarter, and we could say the number of patients detained. And that was pretty much it. Because we collect this data in the Mental Health Services data set now, we can break it down a lot further. So we can break it down by ethnicity, which we never could before, and that gives us a view, which feeds into, as I mentioned there, the Cabinet Office's ethnicity facts and figures. We can also understand patients subject to repeated detention. So in 1718, 15% of known detainees were detained more than once. We never knew that before. Now that we know it, we can start to look into why it's happening and what we can do about it. This is where data can start to help. Right, so the data set. It's working towards becoming the primary source of mental health data, supporting the healthcare system. And I chose those words very carefully. We're working towards it. We don't claim to be there, we don't claim the data is perfect, we don't claim our collection systems are perfect in any way, but that's what we're working towards. We're trying to improve it. How are we improving now? We're improving coverage. As I mentioned, a couple of months ago we were at 170, we're now at 202. A year ago we only had 100 providers submitting data, so we're making a big effort to increase the coverage of it. We're increasing the completion, so not only are more providers sending us data, they're sending us more data, which allows us to do more analysis. We're trying to get data out to anybody who wants to use it faster. We've improved our infrastructure, which I'll come into in a minute, and we're trying to make our processing times faster, make our publications faster, and make our extracts faster. So current benefits, single version of the truth, all submitters submit the same data set, so hopefully there's consistency there. We can compare between organisations, which helps with benchmarking and understanding good service and services that need improving. We can show how services improve over time. We can show how the waiting times for ERP have reduced, how more patients are being seen quicker, which is generally a good thing. All age groups from a single source. For the last few years, we have all children and adults in the same data set. We can give a national picture of a service, and we can link to other data sets. Part of my other work is maternity. We collect maternity data as well. So we've got maternity and we've got mental health. And there's some comments earlier about perinatal services. We haven't got any data on perinatal. Shall we have another return? Shall we write to all providers and ask them what their perinatal services are? Or can we combine the mental health data set and the maternity data set, and that it gives you lots of details about your perinatal services? And that's what we've done. We've been publishing the data for a while. Again, we do not say the data is perfect, but it gives us a national view of services. And that's done at no additional burden to providers. And we can link it to lots of other data sets, so we can start to understand the fuller patient pathway and the full patient journey. And as I've mentioned, data can be extracted and used for other organisations. So, we've already got lots of things planned. We already try to provide lots of benefits. We've got more things planned. We've refreshed our infrastructure. It was difficult to go live. We went live in 1st of April with it. Didn't go as smooth as we would wished. But the benefit that we've got now, we're creating something called a data access environment. That's allowing even easier access to our data. It will allow us to process the data quicker, so we can get data out better, and it will allow approved users to directly access the data. Anybody can ask for our data, and subject to all the controls that we put on, they can get our data and they can use our data. The controls that we put on are strict. So if a researcher wants a list of all patients seen in England for a certain time period, a certain demographics, we say that's fine, here's the data. What are your controls? How are you going to store this data? What's the security of the systems that you store the data on? How are you going to delete the data? How are you going to make sure that only appropriate people access the data? And that list of things that we ask can be quite onerous, especially for smaller organisations. What we're saying with data access is the data sits with us, all the controls are with us. You can request access to the data. So you can do your analysis on our systems. Again, we still ask you lots of difficult questions, but the technology makes it easy for you to do that on our systems rather than reproducing your own systems. And we'll produce a lot of analytical and visualization tools that we could use in our data. We're also saying, well, we have lots of national data, not just mental health, but maternity. We've got hospital episodes data going back 2004, I think it was, going back a long, long way. We've got IAP data, we've got learning disabilities data, lots and lots of broad data, which, if you have the appropriate rights, you can connect to and link and find all sorts of things about the patient journey. You may well have collected your own data as well. So why not bring your own data to us? Bring your data, load it onto our systems, and connect your own local data to the vast amounts of national data that we have. And that will give even more insights into how data can be used and how the benefits that we can have from data. All subject to robust information governance controls, which are very, very strict, as they should be. Right, I meant to start my clock before I started this talk, so what time did I start?
We've got a couple more minutes.
I've got 2 minutes, right, thank you very much. So the 3 types of data we mentioned: aggregate, we ask you how many; the data set, we ask you to send us a list of your patients every month; and then we do surveys as well. We do quite a few surveys. What I've mentioned is the Children and Young People's Health Survey in 2017. This is a detailed survey. This survey covered 9,000 children registered at English GP practices. Yes, lots of questions. It's a population-based survey. So if these children actually came and had NHS services, we would know something about them. If they didn't, if they had a mental health condition and didn't present at the NHS, we would know nothing about them from the dataset. The survey covers these patients. So it's a population-wide view rather than a view of patients in contact with services. We've carried out this survey 3 times, 1999, 2004 and 2017. And we've expanded the survey in 17, so it covers from 2-year-olds right up to 19-year-olds, gives a full view. I have some slides from the survey, which I'll go through briefly. That's just an intro slide from our publication. There's a widespread perception that children are more troubled than previous generations. The evidence shows that there has been an increase. The evidence shows it's gone from 9.7% in 1999 to 11.2% in 2017. Is that more or less than people were expecting? There's a general thought that it's a bit less than people were expecting, but this is the evidence. So it's, again, population-wide view. 1 in 18 2 to 4-year-olds had a disorder. So that's 5.5%. 1 in 10 5 to 10-year-olds had an order. It's 9.5%. 1 in 7 11 to 16-year-olds had a disorder, 14.4%. And 1 in 6 17 to 19-year-olds had a disorder. That's 16.9%. That shows a trend that mental health disorders get more prominent as children get older. There is a strong connection between mental health and physical health, which has been known about for a while. This is giving some strong evidence that that's the case. Self-harm or suicide, 1 in 4 11 to 16-year-olds has a disorder, has either attempted suicide or attempted self-harm. An exclusion from school, more common in children with disorders, which may not be unexpected, but strong evidence there. So 1 boy in 10 with a disorder has been excluded from school. And that's it. Sorry for rushing through those at the end, but I wanted to give you the time.
Wonderful. Thank you.
Okay.